Hello, everyone. Welcome back to another module of drug resistance or management of drug resistance. In this module, we're going to look at the renal insufficiency. So when you have, how are you going to manage patients with renal insufficiency that are also on drug-resistant TB? I'm Dr. Abel Craig Modiba, who's going to be taking you throughout this module. Now, something that you need to remember is that the HIV-associated nephropathy, which is commonly called HIVEN, it's also common. And then tenofovir renal toxicity, meaning the toxicity of the kidneys due to tenofovir. Dolutegravir produces small increase in serum creatinine after it has been studied, but it's a temporary thing in the kidney. Aminoglycosides, renal toxicity, your amikacin, your electrolyte disturbance, and their roles in prolonging the QTC. Remember, we've discussed in terms of your potassium that could have impact on your QTC. DKD, your diabetic kidney disease, is present in approximately 40% of all diabetic patients. What is important is to prevent dehydration and electrolyte disturbance. So these are some of the facts that you need to remember with kidney or renal. Now, in terms of the drugs and its adjustment when you have renal insufficiency, we start adjusting the doses when the creatinine clearance is less than 30. So when you're calculated and your creatinine clearance is less than 30, there are certain drugs that we are going to be adjusting. The one that we are not going to adjust, paracolin, is not going to be adjusted in terms of when you have renal insufficiency. Even if the creatinine clearance is less than 30, it's not going to be adjusted. Linezolid, no adjustment necessary on it. Levofloxacin is going to be adjusted. So what is going to happen, since it's initially given daily, when you have a creatinine clearance of less than 30, you're giving 750 to 1,000 milligrams per dose 3 times per week, not daily as initial. So if you have a creatinine clearance less than 30, you're going to give it 3 times a week. Moxi, on the other hand, it doesn't need any adjustment. Same as clofazimine, no adjustment. Terazidone, we are going to adjust it 250 milligrams once daily or 500 milligrams 3 times per week, not daily, when we have a creatinine clearance of less than 30. So that's how we are going to be adjusting it. Whereas delanamide, it does not have any adjustment required, even if the creatinine clearance is lower than 30. The other drugs also, ethambutol, it's also going to be adjusted to 15 to 25 milligrams per kilo per dose 3 times per week, not daily. So it's going to be adjusted. It's not going to be given daily when the creatinine clearance is less than 30. Parazinamide, it's also going to be adjusted to 25 to 35 milligrams per dose 3 times per week, not daily. So we are going to avoid daily. So it's going to be given 3 times, just like the ethambutol. Whereas your epinemin, for creatinine clearance of 20 to 40 dose, it's going to be given 500 milligrams 8 hourly. But when the creatinine is less than 20, it's given 12 hourly. Whereas, you remember, aminophenol have to go together with amoxicillin clovolate. So amoxicillin clovolinate, it's going to be given 250 over 125, given 30 minutes prior to epinephrine. So the adjustment for epinephrine will be depending on the creatinine clearance level. Whereas meropenem, given also with amoxicillin clovolate, meropenem 1,000 milligrams every 12 hours for creatinine clearance that is less than 30. So it's not dependent on this 130. It's less than 10. Those will be given 1,000 a daily. Whereas amoxicillin clovolinate 250 over 125 milligrams given 30 minutes prior to imipinib. So those are the changes that you need to be aware of. Whereas your terpenem, which is not commonly used, given your amoxicillin clovolate, your terpenem you're going to give 500 milligrams daily. Your amoxicillin clovolate 250 over 125 given 30 minutes prior to imipinib. So whereas isoniazid, no need for adjusting, even if it's less than 30. Etonomide, no adjusting. Your PAS, your para-aminoacylic acid, your PAS, you give 400 milligram per dose twice daily is a maximum dose. So there is a bit of an adjustment twice daily. Amikacin, you stop it because it's very, 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 very toxic when it comes to the kidney. So it causes problems on the kidney. So it's avoided. You stop it when you have a creatinine of less than 30. Rifabutin, no need for any adjustment. Now, in conclusion, management of DRTB in this situation can be very, very challenging. So it's always important that you seek advice, especially when you're not sure. So be aware of, be aware that while improving the ART and non-communicable disease program, we will be challenged with more comorbidities in the same patient. So you could have more comorbidities in one patient. So while the management is complicated in these circumstances, still good treatment success rate of treatment are achieved if patient is managed adequately. So if need be, ask your experts, ask your committees. So you need to be multidisciplinary if you want a good treatment success for the patient with DRTB. Thank you very much.